Hello and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 11th podcast, we'll focus on the February 2024 issue on liver transplantation and transplantation oncology. The landscape of liver transplantation is changing rapidly. The indications, needs, and access to organs are evolving, and the surgical community needs to be kept abreast of the latest developments and emerging concepts in the field. Here to discuss 4 articles from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the liver transplantation issue, Dr. Shamul Shah, the James and Catherine Orr Endowed Chair in Liver Transplantation and Professor of Surgery at the University of Cincinnati College of Medicine in Cincinnati, Ohio. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John, for the introduction as always, and welcome, Dr. Shah. Thank you very much for joining us today. As you know, you and I started talking about this issue probably 12, 16 months ago, after being introduced by one of our colleagues. And normally for transplantation, we've usually approached it in the series as a broader topic. But I think your idea to focus this on liver transplantation, in particular for treatment of other diseases, is a great addition to our series. It's something that we really have needed for a while. So thanks to you and all your colleagues for doing that. As the usual format with this, we picked out 4 articles to highlight. Certainly the interested readers and listeners should go and read the entire issue cover to cover, in my opinion. As a former educator, this is the kind of stuff I would hope that people would know while we were doing our work, not to mention for the practitioners. But I thought we'd start off with the first chapter I'd like to start off with, I think is a little broader, is on the boundaries for transplantation, liver transplantation, for hepatocellular carcinoma by Doctors Lindeman and Magella Doyle. So in broad sense, I want you to start with whatever opening comments you have, but lead that into sort of the inclusion criteria. Who do we consider this for?
Yeah, thank you, and thank you for having me and the opportunity to work on this project. It's been a great experience, and I hope the readers and listeners as well get a lot out of the issue, as you've mentioned. A couple of points I want to make as we get into this first topic is just to set the reference and how did we think about transplant oncology as a focus of this issue outside of just talking about liver transplantation. And there's a couple things to keep in mind if you don't know that much about transplantation. One is that the organs around the country are increasing. In fact, they're increasing at a very high rate right now. So there's more transplants being done every year. And our indications for transplant are also changing. We've gotten rid of hepatitis C. Alcohol is still on the rise, especially with the pandemic, as is fatty liver. But Hep B was never very popular in the U.S., and Hep C is basically gone. So now there's a new indication, especially with more organs, and that is to help treat patients with liver-only cancers, whether it's primary or metastatic. And this is really becoming such an exciting area in our field that I was so excited to try to focus on a lot of these current topics in this edition, because I think this is going to be more and more a rising indication for transplant in the U.S., North America in general. And it already is around the world, but we were a little bit behind on some of these aspects in oncology and in transplant. So here in North America, we've been struggling a little bit to catch up. And HCC, we've been transplanting for a long time. And we initially were doing way outside of criteria. Then we focused in on just the Milan criteria. And then over the last decade to a decade and a half, we've been expanding and trying to figure out what are our boundaries. We have about 10 or 11 different criteria now around the world, whether it's the UCSF, whether it's Toronto, whether it's, besides Milan, there's all kinds of criteria that are out there. And the million-dollar question is, what's the limit? And so I wanted the authors to really focus on helping us understand where is the limit. And I will tell you that we still don't know. I actually think of all the cancer operations we do in the right upper quadrant, the liver transplant might be the most effective cancer operation for HCC out of any cancer that we deal with. It's not a Whipple for pancreatic cancer. It's not a resection for cholangiocarcinoma, but it is such an effective treatment that if you're within Milan criteria, our results are so good that we said, okay, let's broaden it, which is not normally what you think about when you think about surgery for cancer. You think about broadening chemo regimens and things like that. So really exploring size and number and what are our limits. And for instance, here in our program, we don't necessarily have limits when patients enter the door. We consider everyone, but because we have so many things in our arsenal, whether it's Y90, whether it's chemoembolization, whether it's subtotal beam radiation, whether it's now immunotherapy, whether it's external beam radiation. We have so many things in our arsenal that we can treat people for 6 months to a year and downstage them to the point that they're now eligible for transplant. And so when you look at that, about 1 in 4, 25% of patients who are way outside criteria can be downstaged to within Milan criteria and eventually get transplanted. And the results look to be similar. Not as good as if you were within Milan criteria or 1 tumor less than 5 centimeters or 3 less than 3, but not statistically significantly worse than those patients. And so by doing this, you're giving patients an opportunity for cure. And so we don't say no to anyone, to everyone, but we do try to treat everyone and get them to what I describe to them in the clinic is, get them to the end zone, the Hail Mary pass to the end zone, and 1 in 4 are going to be able to be eligible for that.
So let's talk a little bit about that. There's a lot to unpack in that great answer. But let's talk for not every reader out there is necessarily familiar with Milan criteria, and I'm old enough to remember before we had them and how we evolved into them, or UCSF. So Milan criteria, single tumors under 5 centimeters, 3 tumors less than 3, bunch of other schemes. So describe some of the other schemes you have in terms of, even though you've certainly prefaced it with the idea that none of these are self-limiting.
Yeah. So the big thing with the Milan criteria is not only the size and number, like you mentioned, but also no vascular invasion. So that's on imaging. We don't see anything in the hepatic veins or the portal vein. The UCSF criteria expanded it. Instead of 1 less than 5 or 3 less than 3, the total tumor diameter can be up to 8.5. There's a Toronto criteria, which is any size or any number. Doesn't matter as long as the tumor is well differentiated. And those are the 3 big ones we have in the U.S., and it just gives you an idea how different they are. What we're seeing, and what was discussed in this chapter as well, is vascular invasion could be potentially taken care of with some of our pretreatments with Y90 and things like that. And so you can see the vascular invasion go away. And if that's the case, then do we consider them? And that's what many of us have been doing. We've been considering them for transplant if the vascular invasion goes away, and then transplanting them with good results.
Yeah, let's talk about that for a second, because, I think that's a fascinating topic. So vascular invasion implies not just radial tumor growth, but also a biological change and an escape platform for viable tumor cells. So for your evaluation, do you rely more on imaging? Do you rely more on total AFP? Do you rely more on circulating tumor DNA? What's sort of your benchmark to determine that vascular invasion is there before we try to get rid of it?
The big thing is the imaging, first and foremost, because I think our imaging has gotten so good, we can see if the thrombus lights up on the CAT scan or the MRI, or whether now it's bland. I've been pushing radiologists to see whether they can biopsy the thrombus in the portal vein. They're not excited about poking the portal vein, so there's not too much excitement there. But I think it's the combination of the imaging as well as the AFP. AFP starts out at 5,000, and if you get that down to 800, 500, 300, that means you're killing the tumor. Because I agree with what you said. You would describe vascular invasion means it's spreading all over the place. But for some reason with this cancer, that's not what happens. And so I think in select patients, they can have the tumors eroded and the vascular invasion goes away, and we consider them. Doesn't happen in all patients, but the ones that do well, I think it's a constellation. Now, ctDNA and circulating tumor DNA, we have not found a solidified role for it yet. We're working on it. We're playing with it, but the data is not conclusive. It's a little bit of a needle in the haystack approach right now so far, but I'm hoping with time we'll have a better understanding of how it can help us.
Tumor escape and then developing metastasis is a little bit like jumping out of an airplane, right? I mean, anybody can jump out of an airplane. The question is, will you land alive, and will you land in a place where you can stay alive? So from that's always been one of the holy grails, is to find out where the polyclonal expansion of a dedifferentiated cell winds up such that it can set up shop in a new organ system or a new venue. But if it's, I guess one of the questions is it not really the fact that the tumor is invaded into vessels, but the fact that the kind of tumor cells that escape, if you invade into vessels, are able to live in an extrahepatic environment? And it would be nice to know if you could predict that by some molecular mechanism.
No, you're nailing on the head. I think this is where we need to spend our time in the next decade, is trying to understand these mechanisms, because we don't fully understand them yet. And you're right. 1 in 4 patients seem to tolerate this very well and do well. So there's something there that we need to learn and understand better. And we need maybe people like you thinking about this, because I think that's a great point, in trying to understand, why does this happen and why does it not?
One thing I learned from being an executive and a manager is you hire people to think about these problems. You sit around all day dreaming up great questions if you can, and then hope that there's somebody around smart enough to give you a great answer, because I can tell you it's not me. I had my day of basic science 35 years ago, and that got taken away by geopolitics, but that's okay. I think there's a lot of young, smart, interested people out there working on it, but I think the same thing comes up. When we look at it, back in Halstead's day, they couldn't spell DNA, right? They didn't know anything about it. 50 years went by. And then after we figured out DNA and started to figure out some of the mechanisms, we went from there. And we hung with an anatomic consideration for tumor progression for probably a century, probably 30 or 40 years longer than we need to. And now we seem to be tumbling writ large to the concept of biology wins. And, my old partner and one of my heroes, Blake Cady, many, many years ago at Society of Surgical Oncology, said that biology is king and that patient selection is queen, if we can forget the gender assignments of this for the moment, and that all the techniques and tricks we have to teach the princes and princesses of the realms. And Blake, who unfortunately passed away in the last couple of years, Blake was way ahead of the power curve. And a lot of my thinking was certainly influenced by spending time with him. But I think, so in terms of downstage, the general idea of eradicating tumor outside criteria, for lack of a better term, within liver, really provides us with 2 separate avenues, right? It's kind of a bioassay for distant disease, and it's also a local response measure for local regional disease. So what are your preferred strategies for downstaging?
You raise a great point, because the question really is, when we talk about biology, is that all the patient needs is time? And do any of these things even matter? And we'll talk about colorectal cancer in a little bit, but you could argue all they need is time, because I'm not sure how much is the chemo helping that much or not. In this case, we really feel like treating the primary tumor in the liver does have an effect on whether it's going to metastasize outside the liver. How is the patient going to do? So there is something to be said about knocking out the primary tumor, whether we tend to favor thermal ablation or radioactive beads or Y90 as our approach, but really every institution is different. And so transarterial chemoembolization is very common. And now, as I mentioned, radiation therapy is huge. We just bought a photon here, and the photon beam therapy, very selective mathematical precision right to the tumor. Patients tolerate it very well. You have to come in and out for about a couple of weeks, and then you're done. So I think our non-operative approaches to the liver are getting better and better, and needing the knife is likely getting less and less in a lot of the things that we're doing because of the science and the technology that's developing. Understanding the DNA processes and understanding genetic mutations and things is got to be on the forefront. And that's why we're using immunotherapy so much now, because clearly it's working somewhat. We just don't fully understand when and how in HCC, but we're now giving it all the time. It's FDA approved, but some patients it works great and some patients doesn't. Clearly, there's an underlying background there that's helping them.
No, and you bring up an excellent point that we really haven't mentioned yet, but to do this effectively, no matter where you are, you need a critical mass of other people who are looking at this through other lenses with you, including the people who look at this from a pure bench level. Because that bringing all the tools to bear is likely to be, I think, more likely to be the solution than having only one tool supersede all the other tools. I think that's pretty much figured out.
It's one of the most attractive things about transplant surgery. It's a multidisciplinary sport, and you need everyone's expertise because it might not be, we're at the very end of the game when we do the transplant. There's a whole lot of folks that have expertise getting the patient to that point. And that's where you need that great team, and the patient should understand that. But HCC has come a long way because we have so many, about 8 different treatment options now.
You've also, in the transplant world, got the best infrastructure for data networking that I'm aware of. And almost every issue we've ever put out in the clinic series, that is probably the thing I highlight most about, that I wish every other discipline and subdiscipline within the world of surgery could look at following its patients and understanding its population as closely as our transplant brethren have done within their group. I mean, I'm not aware of that being done anywhere better, certainly in the U.S. Maybe some other countries where they've got really rigid healthcare systems might have a shot at some pieces, but transplants got to be the archetype we should aspire to.
Yep, and cardiac has followed that now as well with their database. And what's interesting about us, whether it's good or bad, you can look me up and see how I'm doing even today, and at what our results are. Yeah, what our results are at our center and what we're doing, even who we're transplanting, how many cancer cases we're doing, and things like that. So that's all available now through our program analysis reports, which does give a lot of granularity to everything that we're talking about.
No, that's great. Well, I'll tell you, let's transition the discussion ever so slightly. And there was another chapter in this series by Aletta Hennigatava and Lunsford on transplant for intrahepatic cholangiocarcinoma. So we're dealing with another set of tumors primarily occurring within the substance of the liver writ large, but certainly of a different cell type of origin. So cholangiocarcinomas, especially intrahepatic ones, they tend to grow and do their business long before anybody knows about it. So tell us a little bit about your thoughts about detection for that, and just generally how we would contrast that, if you would, to HCC.
Yeah, it's exactly how you describe, because you can get cholangiocarcinoma with a normal liver. So you're not getting screened for it, and you can just pop in, and next thing you know, you have a big 10-centimeter tumor in a normal liver, nothing you did, and it's basically a cholangiocarcinoma. So I think there's 2 different types that we should just make sure we're clear on. One is there's the small intrahepatic cholangiocarcinoma, and then there's the large or multifocal ones that are in the liver. The small ones, we believe, actually function the same as HCC. Less than 3 centimeters, they do just as well as an HCC. So we treat them like HCC, where they can be transplanted as long as you treat them, watch them for a little while, make sure they're okay. But 3 centimeters, pretty small and a pretty select group. What this chapter talks about is, it does talk about that, showing that those patients do well, and we are pushing that through UNOS currently to get exception points for the small intrahepatic cholangiocarcinoma. But the larger ones, and we all know from resections, and I do a lot of HPB surgery, those patients don't do well. You can take out the right lobe and take out the tumor, margins are negative, and 3 months later, the left lobe is filled with tumor. So those patients don't do well. Survival is poor with surgery. Survival is poor with chemotherapy. And so a couple of groups have done amazing work of actually thinking about, again, getting back to your point about biology, but thinking about a regimen, a protocol of treating the tumors with chemotherapy maybe some liver-directed therapy, but primarily systemic chemotherapy, watching them for at least 6 months. And if they're stable on chemo, hey, let's consider a transplant. Just take the whole damn thing out and put a new liver in, as long as there's no disease anywhere else. And the results were surprisingly really good. And this work was pioneered when Dr. Lunsford was in Methodist in Houston, where they were showing some survival. Patients had 10 tumors and did not recur. So this really launched the idea, again, about thinking about biology, but thinking about, should we transplant this cancer? We're not there yet overall, everyone thinking that it's that safe. But this is cutting edge work that's being done. And this highlights that, again, think about it. There's select patients that might actually really benefit because they have no other option.
So this is one of the tumors that I've always sort of wondered whether or not it behaves in some analogous manner to pancreatic ductal adenocarcinoma versus intraductal adenocarcinomas of the pancreas, main branch, side branch. And it seems to me that some of these tumors progress along the ducts, and some of these tumors just sort of grow into whatever they want. Not to give them personality or anything. But biologically, to me, it seems like there's got to be something different in the core DNA derangement that causes these tumors to slither along your biliary endothelium versus just grow into whatever's nearby. And that leads me into another question that we've wrestled with, and going back to Blake, Ricardo Rossi, and I were really curious about whether or not lymph nodes really matter ever in the grand scheme, or whether they're just some temporary placeholder for us along the way to a better understanding. Because one of the things discussed in this chapter is sort of a need to either do primary resection or lymphadenectomy or something. But again, it goes back to our previous discussion a little bit. How do you know that whatever you're taking out is contained within the liver versus not? So what are your thoughts on lymphovascular involvement and assessment for it, and how to work your way through that?
That's why when we're looking at transplant data, we have to be careful, because these are all node-negative patients. So our personal experience here has been, we have had 3 patients go and get lymph node dissections for this cancer like this. Microscopically, 1 or 2 of the lymph nodes had cancer in them. And so we had to rule them out for transplant. And I think it's very important, because it is now in the lymph nodes, it's outside of the liver. And the intrahepatics, like you say, it creeps on you. And somehow it creeps into the porta hepatis outside the liver. But when it does so, we can't transplant you. And so when I presented some of this work in Europe, they were very against transplant, because they said there's very few patients like this that exist that are node negative. So yeah, you can pick a patient here or there, fine, yeah, you transplanted and they did okay. But by and large, 7 or 8 out of 10 of these patients are going to be node positive, and you're not going to offer transplant to them. And they actually had to stop a couple trials because of that. They couldn't enroll anyone. So I think it's important, and I do think understanding it does behave like pancreatic cancer. I agree with you in that sense. It's super aggressive, but they have to be node negative. Otherwise, we don't have anything to stand on.
Yeah, I mean, so back in the late 80s, early 90s, when I got into the HPV game, we had a batch of people that we believe were node negative for periampullary carcinoma. And then when we got better techniques of evaluating lymph nodes later, we found out that there were about 70% of people that actually were node positive we just didn't know about. And you can't really go back and rewrite your old framework based on your old patients, because you don't have the ability to do it all. But it certainly makes you stop and wonder that a lot of the stuff that we thought we knew we were talking about, we really weren't right. And so picking it up from there, I mean, the other problem, I guess, in terms of liver, either living related donor or other donor being available, even though the numbers are going up, a lot of people with cholangiocarcinoma, their livers working synthetically. So what are your thoughts about that and the relative unimpressive MELD score or such criteria in terms of organ allocation? Where do we work our way through that?
It's a topic of much debate, and that's where, are you going to transplant someone who has ascites or has confusion related to their liver disease and has trouble living, or you're going to transplant this person with cancer because you're trying to cure them, but they're actually doing okay. But the argument there is you're trying to cure their cancer, and their cancer is otherwise incurable without a transplant. So I am a proponent of transplanting them. Otherwise, their survival is around 10 to 20% 5-year survival. You could offer them a 60 to 70% 5-year survival if you can get them transplanted with no negative disease. So there's a real gratification there, not only for the patient, but also from a cancer surgery perspective, if we can pull it off. But you're right. It's a little bit of a dealer's choice. Who do you think is more valuable to save, quote unquote? The sick cirrhotic that maybe the MELD score is 15, but they're in and out of the hospital and suffering and can't work, or the patient with cancer that you're trying to cure that's maybe 2 out of 10 can be cured because they actually meet the criteria, and you don't know yet because you got to first take out the nodes and stuff. And we've been down the path of both, and it's tricky.
Well, the old phrase that where you stand depends upon where you sit. People obviously have their own biases and precognitions and value judgments. And I think you bring up the right point, at least I believe you are, that you can't get too moralistic about this. There's still ways of looking at value-based decisions that don't require moral judgments. So, I mean, certainly the original kidney dialysis funding and transplantation all came out of eradicating those panels who, back in 60 plus years ago, you saved male breadwinners above all else, who are usually white, to make matters that much worse. But today people can't imagine that if they haven't read the history. But it wasn't that long ago that kind of stuff focused in. And I think you just have to look at value propositions, and those are hard. Because if one believes that we have all the resources to do everything for everybody at every time under every circumstance, then decision-making gets really pretty simple. As soon as you think one of those things is not unlimited, that's when you have to start looking at things from the top. And I will say that my own biases were reflected to me. When I was in charge of gut services, I had one set of biases. But when I became in charge of an entire hospital or an entire hospital system for a region, or when I worked for the government and I was responsible for everything from the Mediterranean to basically Pakistan, you have to look at things with a different set of value propositions with limited resources. And we all should do it. And I encourage the readers of this series to think about themselves always as members of the community, and that you need to advocate for the community, not just for your one piece of it. I hope my own hypocrisy doesn't hold me back over time, but I try. But those are hard things to work through. And if you're, all of our screening propositions, right, they're based on the fact that everybody, at least in the U.S. profile, whether you're Bill Gates or whomever, or whether your guy lives under the bridge, everybody gets the same dollar value ascribed to a year of life. That's pretty egalitarian, and it's probably the right thing to do. But those are societal things that we probably need to educate patients, communities, administrators, legislators about, and then at the end of the day, they have to have some say in the matter. Probably shouldn't leave it all to us, even though we usually think they should, but we probably shouldn't, not unless we're willing to fork over the bills. But no, it's a question. And I think not that this specifically translates it, but if we go into the chapter by Sonnenday, we're really moving down the biliary tree ever so slowly in an inferior fashion to get to the hilum. He writes, and I think it's interesting for the reader to look at these two chapters very, very, read them both closely together and look at them closely together, because they're definitely looking at the same problem through a very different prism. And hilar carcinomas, I don't know about you, but when I did this full time for a living, these things, they cause you to up your game. You're especially if you're not a transplanter. Like for me, for just a resectionist, you got to really think about how much damage you're going to do to the other side of the liver when you start doing this, or else you're going to wish you were a transplanter, right? Smart. So talk to us a little bit about how your thinking changes for the hilar cholangios, particularly in terms of like diagnostic measures, because to me, the big concern is, the big takeaway lesson is, do not poke these things percutaneously.
Yes. So I thought his chapter was fantastic, because one of the things, and as you said, I think you got to read it. When I just recently reread it, and I haven't told him this, but his part about the operation is fantastic. Um, Clearly someone that's done it a lot. Now, I do a lot of resections as well, and you nailed it on the head. The resection, I think, is the hardest general surgery operation that we do, at least for sure in cancer, because there's a lot of decision-making that's made beforehand, and there's a lot of decision-making that's made in the operating room. A lot of margins, a lot of things you got to look at. And I always tell my colleagues and my fellows, the transplant's actually so much easier than the resection, because you go in and you just take everything out, and then you just got to put the new liver in and plug everything in. But this is an example of the multidisciplinary care where, one, pre-op, you have to make sure this is unresectable. Because if this is at all resectable, we should cut all of these out, because the results are a little bit not as good as the transplant patients, but they're also not comparable because these patients might have positive nodes and things like that. So you have to make sure they're unresectable. And by unresectable, we mean on a couple of different ways. Their functional liver reserve is small. It's invading blood vessels to the side you're going to save, so then you can't do it. Or the tumor is progressing up both ducts, so you can get a negative margin. Those are really hard things to sometimes assess by MRI, but you need to have great liver radiologists and great colleagues that can say, I think you can do this. But you just got to go to the second radical. Or, no, you can't do this, that liver reserve. Or we can grow the right lobe and let's see if it gets better. So once you determine it's unresectable, then fine, we head down the transplant road. But if it's not, we should always resect these. We've had much discussions about whether we should be transplanting resectable hilar cholangiocarcinoma, and I don't think we should be, and the consensus is that we should not. But because that operation's hard, what gets hard sometimes is you convince yourself it's unresectable. Let me put him to the transplant pile. And we go down the transplant road, and that's happened a couple times. So as a transplanter that does both, you straddle both sides of that about whether it's resectable or not, but it's important to be to really be realistic about both options and make sure that you can just get the patient the best treatment they need.
I think one point you bring up, and I'm really glad you did, but I'd love to underscore it. I don't think we can overstate the value of having another clinically capable partner look in on these operations, because there comes a point when the go, no-go decision, it's not based on anything objective you can point to on a CT, an MR, whatever, no matter how good your technology is. At a certain point, the individual has to make the call. And having somebody there so that you don't let your own emotionality either cause you to bail early when you had a good shot or progress when you really were walking off the ledge. Having somebody else who's not the surgeon of record, to me, is invaluable for any operation where suddenly clinical judgment is going to come into play in a very meaningful way. Because you know how it is. You get to a certain point, the next thing you cut, you're committed to go to the end of the road.
Yes. We do these operations to surgeons, or at least the second surgeon is available for those points to make sure you're going to close and you're not going to proceed. Or, hey, we're going for it. Can you help me go through the liver and I'm going to cut the bile duct, that kind of thing. But you need two surgeons there. I think this is, again, probably the biggest operation that we do in terms of all the different facets of it. And having another person there actually just relaxes also the other person. And we can be even maybe more aggressive because we know we have another pair of hands there with us besides our fellows and residents and things like that. It just adds that comfort level, exactly what you're saying.
Well, I mean, there was an interesting study done a long time ago. It was probably the 70s or 80s where they did biometrics on surgeons, the same as they would do in biometrics on naval aviators. And they found that surgeons operating with just a resident, particularly on stressful cases, had the same sort of biometric data that naval aviators landing on carriers at night had. And then if you brought in a second fully trained surgeon into the room as an assistant, their biometric data was pretty close to wherever they were normally. But the idea of it's a mental game. I mean, there's a technical skill set, but there's an emotional, psychological skill set. And surgeons are humans too, despite contrary beliefs. you walk into the OR and you carry the baggage of your life with you, and it's always good to have somebody there to help keep your head in the game. We wouldn't feel bad about any professional athlete being coached. We don't feel bad about two pilots in an airplane that can fly itself most of the time by computer. But a lot of people get wound up about, I don't need another surgeon. It's like, no, you do. And I'm glad you guys have it as a protocol. If there were one thing in my career I could have changed, it would have been in many situations to say, for the critical portions of X type of cases, two surgeons is not a luxury, it's the minimum. I think I convinced a lot of people along the way, but I never made it a rule.
I quote for this operation, for the resection, a mortality of 10 to 15%. The mortality of a transplant is 3%. The mortality of a cabbage is 1%. The mortality of a brain tumor excision is 1%. So it just gives you an idea. And sure enough, nationally, it's 10 to 15%. And even in my own hands, it's about 10%. So I think it's important that we understand what we're talking about there. It's a big deal.
No, I think you're right. I mean, just briefly, two things I want to touch on before we leave this chapter. But one of them was basically, I agree with you that the description of the operating stuff that Sunday puts in there is arguably the best I've seen. My only lamentation, and maybe you can help us fix this, is why he didn't discuss with the same detail the liver outflow, the venous outflow. He just sort of left it to put the liver in the way you like to do it. I mean, so do you want to give us some insight? He had every other description, every artery, every vein, every bile duct, down to the end. And I'm hanging with bait in my breath to say, what's he saying to say about the cava? And he just rolled right past it.
It's kind of at that, if you're at that point, it's kind of like the boring part, because he spends a lot of time talking about the hepatectomy, because due to the radiation that the Hyler patients have gotten and the chemo and the tumor itself, the hepatectomy can be very tricky compared to a regular hepatectomy, because the portal vein is now kind of stretched out and thin from radiation. The artery may be shot, so you have to do a conduit. So he really does a great job of describing those things. Once the liver's out and you have negative margins, the nodes are all good, and a lot of the hard work is done. And the outflow is actually the easy part, because it's the portal vein that you're sewing in, and the artery, whether you have to use a conduit or not, that is where your mind is now going, oh God, I hope this artery is going to be okay. Not the vena cava, because that's all clean. That's away from where the tumor was. So I think that's probably why he didn't give it much thought. And there are many ways of putting the liver in, and that's just dealer's choice as to how you want to put the liver in from a vena cava standpoint. So that's probably why he left it alone.
No, and I mean, I get it in theory. I'm just, in the series, we try to have this sense of completeness for the people who don't do it. And it's just the one last thing. It's like, I would have been really curious to have him put down what his particular personal preferences were, if any. I mean, again, it's always good to have multiple tools in the toolbox. And then the last bit is, let's talk a little bit about sort of the Blumgart sort of scoring mechanism in terms of resectability. It really comes down to, these T1, T2, T3, and then Mets. And so other than we talked about the intraoperative decision-making, what's your best source to rely on, the pre-op assessment for that?
Yeah, that's really using a high-quality MRI to see how high up the bile ducts the tumor's going. And if you are going beyond the secondary radicals of the bile ducts, it's unresectable. So you can go up the primary and you can get to the secondary. If you think you can get a negative margin there, then you're okay to proceed. And so that's where the T1 or the T2 is okay. T3 would make it unresectable. And that's where we'd think about a transplant. But that's really based on having a good MRI and actually having a really good radiologist that can try to tease it for you. Because a lot of this just looks thickening. Those are some of the words you're going to hear. There's some thickening there. I think it's going up there. Sometimes you don't really know, then you got to look. And the tricky thing about this protocol is if I go in and try to resect you and I cannot, you are no longer eligible for a transplant. So that's why the preoperative planning is so critical about resect or unresectable. And because if I go and try, I really hurt you if I can't do it, because now transplant's off the table.
All right. Well, the last chapter that we sort of, we're going to get outside the liver only to get back into it. So the last chapter we have is on colorectal cancer metastasis, and I'm not sure if it's pronounced Shepherd's or Sheepers, I apologize, Hartman, Whitrock, and Quillen. And again, I mean, colorectal cancer, as everybody knows, and they're really, obviously there's colon cancers and there's rectal cancers and maybe a few that share some commonalities, but they're not all the same. But nonetheless, those that have portal venous distribution have a very high likelihood of winding up in somebody's liver. So this is common as dirt. And so walk us through your thinking on colorectal mets.
Yeah, 50% of folks develop liver mets that have colon cancer. And the tricky thing here is it has to be confined to the liver. So you have many patients out there, many, but it's still a small amount compared to your whole population that are living with liver-only disease that is unresectable. And so they've been getting chemotherapy for 4, 5, 6 years because there is no other option. As long as it's liver only and they've been getting chemo and they're stable on chemo, they should be considered potentially for a transplant, especially if they're not doing well on chemo. What we can offer them, and this is an extremely controversial area, which is why it had to be included in the book, because we've only been doing it in this country for a short time. It was perfected out of Oslo, but again, very small subset of patients, 60 patients over a decade, so not many. But the main thing that we can offer a patient is chemo-free living. And so if you're a cancer doctor or you've had cancer, you know what chemo-free living is like. And that's what we're hoping to accomplish with the transplant. The first patient we did was diagnosed in 2012, just to give you an idea, was on chemo for 7 years. When we opened our protocol, our oncologist came up to us and said, I got the perfect patient for you. And we reviewed it. We're like, oh my God, 7 years of chemo. This is perfect. The guy's been stable and sure. And we did his transplant. And the problem with the transplant is a lot of them recur. And so we have a 50 to 60% recurrence rate. And believe it or not, it's not in the liver, it's in the lungs. After 7 years of liver-only disease on chemo, 1 year later, this guy recurred with a spot in the lung. And we all looked at each other and said, that makes no sense. How come he didn't recur earlier? So there's something going on with the immunosuppression, with this. Actually, we resected his MET. That was back in 2019, we transplanted. 2020, he had the MET. He had it resected. He's still doing well with no other lesions, which again, flies in the face of metastatic disease. So it's a weird population. We're trying to understand it. Gets back to your initial point. It's likely all about biology, and these are highly selected patients, maybe 5 or 10 out of 100 that are probably eligible for this treatment.
Yeah, but I think your observation's spot on. And we may not be right, but we agree on the analysis as well. Just analogously, when I was younger and did a lot of esophageal work, we started getting into doing neoadjuvant therapy for a lot of people, and especially as adenocarcinoma became the predominant subtype. And what we found after people were getting neoadjuvant chemo-rads is that when they presented with recurrences, they were in the weirdest of places. We had people showing up with skull mets and body wall mets. And it wasn't coming back in the mediastinum, and it wasn't coming back to places where people used to fail. And we attributed that in part to we had pre-treated a region with local regional care, but in part that there was probably some there's an immunologic change to everything we do. I think most people would accept that. I don't want to be too broad a brush, but there's a big immunologic chain when you're immunosuppressing somebody to have a transplant. And so, you wonder if it isn't loss of or alteration of immunosurveillance that then makes the other organs prime to get something back, because it's clearly not the same cell going to the same liver anymore. I mean, it's not the same person's liver.
This is exactly what we need to work on, and this might be a role for ctDNA because you're removing the liver. So you check it beforehand, you see where you were at, what's your baseline. You take the liver out. That means all the cancer is now gone out of this body. And we start following for these markers and seeing what changes. And is that a way for us to pick up early recurrence or determine are there certain markers where we should not be doing this? Now, we have certain genetic profiles that we're not doing. and that are specific to the metastatic colon cancer. But I think there's a role now for some of this molecular analysis because the disease has been removed on day 0, and then we can follow them. And I think we can get better at trying to understand exactly what you're saying as to why they're recurring and where they're recurring. And it doesn't make any sense.
Well, that led me into literally the very next question written under here is molecular subtyping and what we should think about it. So what do we think about microsatellite instability? What do we think about, BRAF mutations? What do we think about other mutations? And I know that our colleagues who treat renal cancer have gotten really good at parsing out subtypes of renal carcinoma. Really good, amazingly good, and hats off to them for it. And I'm wondering if we're not maybe entering that phase a little better on colon tumors. We certainly have a large group of people with tumors to study compared to other tumors. Huge sample size with the number of people in this country that get colon cancer in a year. But I think, what are your thoughts on molecular subtyping and trying to predict?
We have specifics here where they have to be microsatellite stable, and they cannot be BRAF. They have to be BRAF wild type. But that's otherwise a no-go. KRAS, believe it or not, unclear, even though we think of KRAS as a bad actor for adenocarcinoma. So no, we are getting there where we're being specific about this, and we're pushing this through nationally in the U.S. for exception points, and you have to follow these criteria. But there's probably other markers there that we can use to help predict who's going to benefit. Because remember, as I always teach the residents, liver transplant is the only operation where you can kill 2 people in one operation. You can kill the person that was supposed to get the liver because you didn't give it to him, and you kill the person on the table because you made the wrong choice. So we're hurting someone else if we give a liver for someone that maybe shouldn't have gotten it for colon cancer by not giving it to someone else. So we have to be really careful as we push this forward for colorectal mets, who we should do, how, why. And so I have taken kind of a guarded approach to it. I'm a proponent of it, but my thing with the transplant community is let's be careful. Let's understand this as we go, because we could make some big mistakes if we go too quickly.
Yeah, and you can actually get 3 people, maybe in theory, if you include living donors, which thankfully is a rare occurrence. But let's talk just briefly, not exactly in the opposite direction, but so let's talk about colorectal mets and then non-transplant, but resectional options that give us enough functional liver reserve. What's your general thinking on mixing and matching resection plus either ablation or what have you?
No, that's why it's important to make sure that you've exhausted every option before you think about transplant. The transplant cases, we've done about 10. The ones I'm most comfortable doing are the patients that have been burned out on chemo, like their livers are no longer working right, they have biliary ischemia, or they had a pump put in, and the therapy is just not working well anymore, or they're suffering from liver failure. Those you feel comfortable about because those patients had no choice but to get a transplant. It's the ones that are unresectable that you wonder, well, they could just stay on chemo and you don't have to do a transplant. We are very aggressive with all the options for resection and have to be aggressive. So we have, besides a regular resection and besides portal vein embolization, we're now doing bivenular embolization. So we're doing hepatic vein embolization and portal vein embolization, everything we can do to try to grow the remnant. We are doing hepatic artery infusion pump, which I think is a great segue before transplant. Making transplant the last possible option by trying everything that we have. The pump is a little tricky because it can make your transplant a lot harder. And so you have to be careful that you make sure that you can do the transplant when the pump is put in. It scars the portal hepatus. But so far, in a couple of cases we've done, has been fine. We have radiation options to colorectal mets. And then we have things like ALPS, which is dividing the liver and letting it grow, and the 2-stage hepatectomy. So we really want to make sure that if you're going to talk about transplant, you have everything in your arsenal that you can pull out before you pull out the final big gun. And that message has to be clear across the world.
No, I think you're right. And I think, when I was working at Leahy Clinic, at the time, it was just before the transplant team came over. And I always felt that even though Leahy had a very storied history with all matters pancreaticobiliary, not to mention colorectal, and it was a great place to work, and I love my colleagues from there and to this day. But I always thought we needed transplant on board to really be the full service center, which they got done after I left. And those are not related events, by the way, but still. But no, I had gone off to Maine to build a program to do pancreaticobiliary stuff where one didn't exist, and that was the right decision at the time as well. But I really wish that we'd had the transplant team on board at the clinic probably before I went there and into my fellowship there. It took them a while to integrate because back in the 90s, there was a weird cultural divide, which I hope is erased. I hope a lot of these cultural divides are erased. Maybe they're not everywhere, but I hope they are.
Well, you had one of the greatest surgeons to come there. So if he can't make it work, I don't know who would. So,
well, on top of that, you could ask just about anybody at Leahy Clinic if they were the greatest surgeon, and you'd find a bunch of people would say yes. And ironically, some of them were. It's if you need a 50-pound box moved, you can find somebody that can lift a 500-pound box or a 51-pound box, and they'll both get the job done. To me, the greatest surgeons are the ones that realize the patients are taking all the chances and who are maximally willing to accept new ideas and work with their colleagues for the greater good. And that, I don't mean to overly moralize, but Ricardo Rossi, who was the chairman when I was there, who's still alive, he's down in South America, but I don't think I ever met anybody that was more capable of bringing new ideas from other people into his practice comfortably. Especially, he got into a level where it was pretty hard to out-operate Ricardo, or outthink him, or out pretty much anything him. But he was more open than almost anybody else I knew. He was so secure in his knowledge base. John Brash was the same way, not to the degree that Ricardo was, but Mike Weidenheimer, David Schetz, you could just go down the list. But, when they brought the transplant team over from Deaconess, which was their old combination, things really took off. But anyway, this has been a great discussion. I can't thank you enough for your time. We're sort of closing in on the hour, but are there any other final thoughts you want to leave the listenership, the readership with?
No, I think your last point about the patients taking the risk and having faith in us as a community to do what we think is best is something that we don't think about much. But that's actually such a great point, especially in something like transplantation, where a lot of it is experimental. And we want to push things forward, but we need the patients to have faith in us. And that's something I hadn't, necessarily, equated so much to, but I think you put it so well. And I think that's a great way to end the podcast.
Well, Dr. Shaw, thanks again to you and all your colleagues for this phenomenal issue that everybody should read just to expand their horizons in their mind. If they don't know this stuff, they want to. Whether they know it or not, they should. So thanks so much again. Really appreciate your time and effort.
Thank you so much, and I thank the authors for their great work and appreciate the opportunity again.
Thank you for joining us for this Surgical Clinics podcast devoted to liver transplantation and transplantation oncology. The 4 articles discussed, as well as 12 others, are in the February 2024 issue, Volume 104, Number 1. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @Surgical Clinics, and you can find our podcast on most major audio streaming platforms. Visit theclinics.com for more details. Thanks for listening.